Okay, asthma. Asthma is a chronic inflammatory disorder of the airways. So we refer to it as RAD, a reactive airway disease, not in a chronic obstructive disease. Because most of the time when people are not having their asthma attack, their lung functions are fairly similar to normal healthy people. Whereas COPD patients, once the diagnosis goes through of COPD, their lung function is never even close to that of a normal person. So if you can control the issues and the underlying patho with asthma, you can pretty much have normal expectations. So it's a reactive airway disease, not an obstructive disease. And you might have heard of exercise-induced asthma as a variant. We'll talk about things going on with bronchospasm. So there are three aspects of pathophysiology for asthma. Number one is airway inflammation. Number two is intermittent airflow obstruction, and number three is bronchial hyperresponsiveness. Okay, so airflow obstruction can be caused by a variety of changes, things like acute bronchoconstriction, airway edema, mucus plugs, and airway remodeling. Over the years, people with asthma, their airways actually structurally change. The acute bronchoconstriction, is the consequence of immunoglobulin E mediator release. Airway edema usually occurs within 6 to 24 hours, and you start to getting chronic mucus plug formation with an exudate of proteins and cell debris that can take weeks to resolve. Asthma results in about 100 million days of restricted activity in the United States, about 2 million emergency department evaluations, 500,000 hospitalizations, 5,000 deaths or so. And mortality has been linked with management failure, especially in young persons. Evidence of respiratory distress manifests as increased respiratory rate, increased heart rate, diaphoresis, use of accessory muscles. Pulsus paradoxus, where there's an exaggerated fall in systolic blood pressure during inspiration. So if you think about taking a deep breath, if you're taking a deep breath and your lungs are remaining hyperinflated, that's going to compress and reduce the ability of blood flow to go back into the atria. So there's going to be a decrease in blood pressure during inspiration. So that changes. Remember that we talked about the respiratory pump, about how blood gets back to the heart. End expiratory wheezing, or prolonged expiratory phase. Diminished breath sounds and chest hyperinflation can be observed during acute exacerbation. And remember that a silent chest asthmatic is life-threatening. And people get thrown off by this and sit there and do lung sounds. And if they don't hear wheezing, they think, okay, this really can't be that bad of an attack. And everyone has to remember that wheezes can only be made by enough air flowing over the airways to get a wheeze. So if there's not enough air moving, then they're not going to be wheezing, which means they're probably right before respiratory failure and needing to be tubed. Asthma management includes objective measurements of lung functions, things like peak flow meters, etc. Environmental control and avoidance of risk factors, comprehensive pharmacological therapy, and patient education. If we go back here, just to address this for a little while, we need to understand that there are a lot of environmental control factors and risk factors that are involved in asthma and asthma management. You can look socioeconomically at incidence of asthma in different areas. They're more often associated with housing projects and a lot of congestion versus out in the fields and out in the suburbs. Lead paint exposure, asbestos in older buildings. Even though it's determined to be a allergic disorder, you don't see what you'd think or what you'd hypothesize to see, which is, wow, if it's allergies, then it must be a lot in Iowa and Oklahoma and Kansas and cornfields and wheat and stuff that's all around. It's really not. So what you need to look at is including and combining sort of 2 and 4 with patient education. Is a lot of it is caused by things like dust mites, which is the stuff that is found normally in dust. We have mites in our own eyebrows and in our hair follicles, which cleanse the oil. They basically eat the oil from the follicles so that we don't get folliculitis and we don't get inflammation from all the oils produced by our skin. So they're these tiny bugs, basically. But when you go face down in your pillow, you inhale them at night, and they get into your respiratory tree. And normally they get broken down, not a problem. In people with asthma, we seem to see that they're hyper responsive to their own dust mites and their own oils. So there are a variety of methods to look at. There are asthmatic-proof beddings and asthmatic-proof pillows, and not sleeping with the puppy in the same room, and not having birds in the house, and pet avoidance, and dander, etc. And you all know that little kids love to have their puppies come up on their beds, and their dogs and their cats, and all you're doing is inhaling all their fur and all the stuff that they've been rolling around in all night, which is probably going to trigger an already hyper-responsive person's asthma. Okay. Objective measures of lung function. If you think about blood pressure management in your hypertensive patients, you have to be doing the same things for your respiratory patients. And we know that asthma and high blood pressure very commonly go together in the neighborhoods around downstate and the areas of New York City. Comprehensive pharmacological therapy means keeping abreast of the latest data, whether you're using short-acting beta agonists, long-acting beta agonists, inhaled steroids, IV steroids, whatever treatment you're going to use. It needs to encompass both short-term abortive attacks as well as long-term anti-inflammation. For pneumonia, we talk about inflammation and consolidation of the lung tissue due to infection. Okay, and pneumonia we divide into basically two types, either community acquired or hospital acquired. So if it's acquired outside the hospital setting, including outside the nursing home setting, that's community acquired, or if it's more than 72 hours after admission, it's referred to as nosocomial or hospital acquired. And you're all familiar with the type of species: S. pneumonia, the Haemophilus, Staphylococcus, atypical pneumonias including Mycoplasma, chlamydia. Yeah. So, pneumonia is generally in the nasopharynx and asymptomatically in about half of healthy individuals. We talk about things like Haemophilus influenza, having viral infections which increase pneumococcal attachment to the receptors. If you know what H. influenza is is actually a bacteria, but it's most commonly associated with infecting people after they've had a viral illness. So very commonly you'll get patients who had the flu a week ago or 2 weeks ago and now have pneumonia. So it's not rare at all. What seems to happen, basically, if you remember what we talked about in bone marrow, is that never let my engine blow. Well, if you have a viral infection, the body's trying to pump out a whole bunch of lymphocytes to attack the virus. While you're pumping out the lymphocytes, the neutrophil count will go down. That makes you a little bit more susceptible to bacteria. So you're getting a superimposed bacterial infection on a pre-existing viral infection. You get about 45% of healthy subjects aspirate during their sleep. Aspiration has a huge role in nosocomial pneumonia. We have a lot of people who can't protect their own airways, your stroke patients, your chronic neurological patients. We all know that hospital beds are really great and the sleeping's really great for promoting things like aspirating your own food. Sorry, the number doesn't come all the way up. There's just some data. About 5 million cases or so of community-acquired pneumonia annually. Lots of nosocomial. Pneumonia is the 6th leading cause of death in the United States, the most common cause of infection. Patients with pneumococcal pneumonia can produce some bloody or rust-colored sputum. Then there's green sputum from Pseudomonas or Haemophilus. Anaerobic always produces this foul-smelling and, my favorite, bad-tasting sputum. Hopefully the patient tells you that it's bad-tasting, not you. Let me try that. We then have Courant jelly sputum, which suggests Klebsiella or also pneumococcus. Just some things that you might see on exams and historically. So your physical exam, your patient's typically going to have a fever or hypothermia. They'll be tachypnic. They have tachycardia or end-stage bradycardia. Centralized cyanosis versus peripheral cyanosis, dullness to percussion, decreased intensity of breath sounds, rales, egophony, whispering pectoraliqui, pleural friction rub, and maybe an altered mental status depending on what their blood gas is and their oxygen saturation is. So you might see a leukocytosis with a left shift, meaning more PMNs, more leukocytes, but may be absent in patients who are elderly or debilitated or don't have an intact immune system. We know that if they have a leukopenia, there might be in immune failure. Sputum exam is only accurate in about 50% of the patients, but should still be done. So you do a sputum CNS and blood CNS, even though it's positive only in about 40%. So the initial approach to looking at patients with community acquired, looking at should they be treated in the hospital or as an outpatient, do they have a serious coexisting illness, or is the patient elderly, and how severe is their initial evaluation about whether they need to be admitted or not. And that's going to be 10 minutes based on the pneumonias and asthma and infection.